Okay, then good morning, everybody. Today we are going to speak on fracture clavicle. As you all know, fracture clavicle is a very common problem. Off and on, we used to get cases coming to our casualty or OPD in day-to-day orthopedic practice. Let us talk how we have to treat this patient, what are the problem we need to face sometime, and some little bit of the anatomy also. So let us talk about the anatomy of the clavicle first. The clavicle is the bone which is horizontally placed in your body. The interesting point in the clavicle is that it is the only bone which is having communications between the axial skeleton with that of the upper limb. So other part of the joint is there, but this is not having a skeletal continuation. Basically, they are having in soft tissue. But here it is the only bridge between the axial skeleton and that of the axial skeleton and that of the upper limb. So it is grossly S in shape. You know, it has got medial end, that and lateral end. This is concavity. This part is convex, and superior. This is superior surface, and this is the under surface. So it grossly it is S in shape. Medial end articulates with the sternum here to form the sternoclavicular joint, and laterally it is communicating with that of the acromion process to form the acromoclavicular joint or arch. This part we know. So it is a S-shaped long bone placed horizontally, medially connecting with that of the sternum to form the sternoclavicular joint, and laterally it forms the acromioclavicular joint. So this is the ends which are very evident. You can see. What is the problem? So next, let us talk about the attachment of the various muscles. So we have many muscles. So many muscles working around the clavicle. So this trapezius having got attachment in the medial border of the clavicle, at the medial border of the acromioclavicular arch. This is a very strong muscles attached there. This is the insertion of trapezius there. And the outer side, in the outer margin of the acromioclavicular arch, we have the deltoid muscle here. So they are synergistic sort of muscles. One is having origin, another is having insertion. They are working opposite to each other. So this is a big muscles attached to the clavicle. So this side you have this beneath the subclavius muscle, and the part of the pectoralis major is also attached to it. So subclavius is down below, but pectoralis major is above. Then you have another group of muscles lying above is your sternocleidomastoid. So grossly, it has got so many muscles attached to it. So grossly, it appears to be very subcutaneous in nature because one can palpate the clavicle very easily. Even then, it has got attachment of various big muscles like trapezius, like deltoid, like pectoralis major, subclavius, and sternocleidomastoid mostly. Sternocleidomastoid mostly. Then this is your various important structures. In one point, one should understand that just beneath the clavicle, we have a important structure lying here. That is your brachial plexus, along with the important vessel, subclavian artery. So these are very much intimately related to it, particularly the middle part of the clavicle, particularly the beneath part of the clavicle. Just beneath this, we have the important structure. So in a situation where there is an injury of the clavicle, there is also a possibility to injury to the important structures like your brachial plexus. Brachial plexus. So on the other hand, that is about the muscles. about the correlations with the important neurovascular component. On the other hand, these are the various ligaments which are important to hold the clavicle in position, particularly the formations of your acromioclavicular joint here, Then you have this important ligament from the coracoid process to clavicle. This is trapezius ligament and coracoclavicular acromial ligament. These ligaments are important to hold the clavicle as a suspensory ligament, just like a parachute. They are holding it. So in a situation when there is a fracture here, and these ligaments are also torn, because of the muscle pull, these fragments go upwards. So this fragment, this area, the clavicle is holding like a parachute with that of your coracoid process by the conjoint tendon. And this is important that in a situation when there is a rupture of the tendon also, there is a possibility of cross displacement of the clavicle. So what are the peculiarities? See, often there is a question. It may come in your entrance also, or earlier in anatomy you must have learned about the peculiarities of the clavicle. So this is also known as beauty bone or the collarbone. As I said already, it is very superficial and subcutaneous. An interesting point in the ossification is the one bone which is ossifying early and also fuse late. So it's a long span. So it is ossification start very early, but interestingly, the completion of the ossification process, it takes a very long time. So it is occasionally pierced by the nerve also. That's the interesting point we sometimes encounter, sometimes we find in case of your clavicle. So what are the functions? Certain important functions, as I mentioned while discussing the anatomy, that is also gives some protections to the underlying brachial plexus, because so it serves as a bony link between the axial and the upper limb, axial skeleton with that of the upper limb. Stable linkage for the shoulder movement and contributes significantly to the power and stability of the shoulder. So this integrity of the clavicle is very important, on which the various groups of muscles work. So if there is a fracture and the base and foundation is not strong, the efficiency of the muscles are also not there. This can be understood with this fact that while a crank is working, while they are lifting something down below, a crank, yes, you must have seen that while a motor or anything or falling down, then a crank is lifting up. While working at this moment of time, they will encourage on the ground with some poles. This is what is important to the integrity of the thing, that where foundation is important, on which basis it can work. So that is why the integrity of the clavicle is important, to have a efficiency of the muscles working around the or attached around the clavicle. So next point is the mechanism of injury. There are two types of injury. One is indirect trauma, another is direct trauma. So in what is indirect, what is direct? Indirect trauma is falling somewhere, the impact of the force is somewhere and is traversing to the clavicle. That is indirect trauma. So if someone is falling, so it is not directly falling on the bone, it is falling on the hand. But the impact of the force is traversing through the limb, and that is ultimately resulting to your fracture of the clavicle. That is a indirect trauma. But on the other hand, there it may be hit by someone else, direct hit, or something falling heavy on the clavicle may lead to your fracture. So this is a direct trauma. So there are two types of injury while working on clavicle. To have fracture is your direct trauma, another is your indirect trauma. So as I said already, because of the fracture, level of the fractures and the muscles working over the fragments, the displacement will be determined. See, in this situation, see, the fracture is taking place here. Since these muscles are pulling up the integrity of the sternocleidomastoids, which is strongly pulling upward, leading to your displacement of this. So this is happening, and had it been a case of your supposing a fracture is here, probably the fragment will not displace because both the muscles are holding this together. So this is to be understood that in what situations it will migrate upward or downward, it all depends upon the fracture level. Next point is that now let us talk about the incidence and the classification of the fractures. We have already discussed what is the anatomy, what is the importance of the clavicle for integrity, working of the muscles, protection of the neurovascular structures down below, particularly brachial plexus. Then we also talked about the muscles. Now, classification of fractures. The mode of injury is direct and indirect trauma. In these classifications, basically it is being divided into three halves. One is your medial 1/3, it is middle 1/3, one is lateral 1/3. So medial, middle, and lateral 1/3. So you will find that most of the time the fractures are taking place in the middle part. So why it is happening so? You can understand that while there is a junction, see this part, this bone is a bit convex here. On the other hand, this part is concave. You will find in a situations where there is a junctional area curvature, there is a chance of injury is more high. And it is seen in the case of thoracic lumbar spine also, while there is a curvature meeting point between the kyphosis and lordosis, that area, junctional area, the injuries are more common. Same thing is applicable here. There is a, while there is a meeting point in two curvatures, the stress riser. It is a area where the stress is more. That leads to your fractures, common fractures. So middle 1/3 is a common place to have the fractures. Well, so that is called Ullmann classifications. Middle 1/3, medial 1/3, and lateral 1/3. So that can be again subclassified in various times. Sometimes we may have segmental fracture like this. Sometimes we may have comminuted fractures like this. Sometimes fractures in the spinal fractures may be there with the dislocation also sometimes, very rarely of course. But there are certain combinations of the fractures are quite common. But nevertheless, it is the middle 1/3 fracture which is very common. Now, while the fracture is a pain place, and now the patient is coming to you with this problem. So what are the problems he is coming? He is necessarily having tremendous pain because of the injury. Then there is definitely swelling at this area. And if you palpate the patient, you will find the tenderness. Sometimes one can feel the ends of the bone. Ends of the bone. One can feel the part of the bone also, the fragment area. So this is an example where one can feel the fracture. See, this area is quite evident. There is a fragment is having fracture there. This fragment is going upward. That is why it is becoming prominent and one can feel it. The ecchymosis is quite common. So in a trauma situations, pain, swelling, restrictions on the movement, and also palpations may necessarily help you to diagnose because the bone is very subcutaneous. One can feel the bone. Any integrity loss or discontinuations anywhere in the can be very easily palpable because of the subcutaneous nature of the bone. Subcutaneous nature of the bone. So now this is a, now if the patient is coming to you in a casualty, you necessarily go for the X-ray. And X-ray, it is the picture is coming where is middle 1/3 fractures. This fragment is going upward and this fragment is going downwards. So there is a cross displacement between the fractures. So, but it is important that in a trauma situations, one should always look for the integrity of the neurovascular component. It is paramount important as is also to be understood that any injuries anywhere in the body, one should always look for the integrity of the distal neurovascular status. be it in the upper limb, lower limb, anywhere. Supposing there is a fracture on the elbow, around the elbow, necessarily one should look for the integrity of the distal neurovascular radial artery and also the nerves. This is important because in a injury, there is every possibility to the nearby important structures like neurovascular structures. So this is a fractures, the X-ray is being shown. This is a comminuted fractures with the displacement of the fragment like this. This is a bilateral fractures of the clavicle, both sides.
Right.
It is quite common. Quite common. Quite common. Now, question arises, if the patient is coming to you, what is your treatment of choice? How we are going to treat this patient? So we are going to talk about the treatment part. We have already diagnosed this patient. This diagnosis is more common with the palpable method. One can palpate it easily. One can get it confirmed with the X-ray. Many times X-ray is sufficient. One view is also many times is sufficient. Now, what are the treatment choice we do have? We do have the two types of treatment here. One is conservative treatment, another is a operative treatment. But most of the patients or the fracture clavicle can be treated with conservative treatment. There is no need of going for the surgery. So most of the patients of fracture clavicle can be managed by conservative treatment. And this conservative treatment, in case of very small size, 1, 3 years, 4 years, 5 years, you do not have to even need to apply for anything else, but only simple collar and cuff is enough. Only simple collar and cuff is enough. But in case of your adult, one should go for a figure of 8 bandage. We'll talk what is this figure of 8 bandage, and it is supported by the arm sling or a triangular sling. So this is a picture of the clavicle belt, which is giving a shape of your figure of 8. See, it is just like a figure of 8. Earlier days, we used to make it with the rule bandage with cotton support. But nowadays, commercially, these things are available. So one can have these things, and also is available to various sizes like small, medium, large, extra large, depending upon the size of the persons. So you can select the size and you can bring it, you can apply it. So one thing is true, the only clavicle is not enough, you have to need a triangular sling. This triangular sling is essentially give you support to the hand. What is important, see, if there is a fracture here, and if you allow the limb to suspend without any support, there is a possibility of pulling down the fragment here. Because of the gravity, because of the weight of the persons, so it may go down. It may go be displacement. So now if the fractures fragments are displaced, if the fragments is lifted upwards and pulled, this is called your bracing back. Bracing back means you hold the person like this and pull it like this. This is called bracing back. Then apply. But apply after applications. It is very important to see the patients. What important that if you are applying this bandage very tightly, then what will happen? Patient will have very discomfort, tingling sensation. He may have compressions over the neurovascular structure down below, may experience little discomfort with tingling sensation. This is not an ideal situation. So the tightness of the figure of 8 bandage is very important. If you tight it very tightly, then what will happen? This will also essentially compress the axillary vessels and nerve there. And this is lead to your insufficiency of the circulation distal below, or there may nerve compression also. Patient may complain of your excruciating pain and also the scaling. So now, then that is your conservative treatment. And if you need to go for the operative treatment, see, in certain situations, the conservative treatment is not enough. There you need to go for the operative treatment. And the operative treatment, as I said, is not essential in most of the cases, but in certain cases, of course, you need to do. And what are the conditions we need to actually need to do operative treatment are basically open fractures. When the fracture is open, is coming to outside, the fragments are lying outside. While there is a tendency that fragment, though it is not outside, but this tenting the skin, it is piercing down of a bit as if there is a possibility it will pierce out. That is a condition where you should go for treatment. Then neurovascular injury, then symptomatic non-union. See, Symptomatic non-union is another thing, because sometimes patients who undergone conservative treatment may not unite the fragment. But even non-union is not a indication for persons. Many a time even non-union patients are also comfortable, do not need to go for operative treatment. But if it is symptomatic, patient is discomfort, then yes, you need to go for operative treatment. So if the fragments having soft tissue interpositions, clavicle fractures associated glenoid and scapular neck fractures, that means if there is a whole anterior and the posterior component of the arch is fractures and the whole shoulder is drooping down because of the fractures in the neck of the scapula or the clavicle, may also whole the structures may drop down. Then you want need to give some support, some upward treatment, either the anterior clavicle or posteriorly, anteriorly or posteriorly. So fracture of the distal 1/3 of ligament abscess and polytrauma patients, yes, we need to go. Well, that is your how one should go for the operative treatment indications I have mentioned. Then what are the techniques of operation treatment? So certain techniques we are simply analyzing here, that there are two ways to do the fixation. Either one, go for the intermediate fixations or go for the plate fixations. So intermediate fixations is one of these techniques here, which is put a nail screws from outside to from lateral to medial. Nowadays, of course, from medial to lateral, medial to medial end to lateral end also coming out. So there are two way of doing. So it is a bit difficult because it is S-shaped, but the nail is or screw is very straight. So sometimes there is a possibility that it will pierce out. But nowadays, of course, another techniques are coming out where the malleable nails are now, elastic nails are being introduced from medial side, give a S shape. That is another technique. So intermediate fixations are two techniques. One is from lateral side, another is from medial side. And what next? If the medial fixation is not sufficient and not happy, so one can go for the upper treatment with various types of plates. Now, plates are having two types. One, where they are pre-contour. See, the shape of the plate is given according to the shape of the clavicle. So these are available nowadays. And also right side, left side also demarcated. Because this one which is for right side cannot be applied for left side. The shape is different. So that is why nowadays pre-contour plates are available when one can do the fixation. So one is intermediate fixation, another is extramedial on the surface along with the plate. So this is another type of your design of the plate, which is a hook plate. This is also plate where if pre-contour plates are not available, then you can apply this plate, making it a contour according to the clavicle. So you contour it, and then you apply it. So these are the various techniques where operative treatment can be extended for the fracture clavicle. Initially, I said that most of the cases can be treated by conservative treatment with the application of the clavicle bed, clavicle bell, but operative treatment when necessary can be go for intermediate fixation or extramedial fixation. Now, what are the complications we may encounter sometimes? The malunion, infection, non-union, neurovascular injury, sometimes we also scapulotrophy dislocations may be associated according to trauma. So most of the treatment injury to the neurovascular status is very important. It is very important because of the trauma, there is a possibility of the neurovascular injury. And also operative treatment may end up sometimes non-union, sometimes malunion, sometimes infection may be there because of the operations. These are not very uncommon, but it may be common sometimes. So, so that is the end of this today's class of fracture clavicle. We will take up more cases later on. If you do have any question, you can ask. You can give me access. Also, you can be in touch. So we'll continue these classes regularly in regular basis in next week. Also, we'll talk fractures of various fractures of the upper limb. Particularly, we can talk about dislocation with shoulder joint and the fracture shaft of the humerus, supranuclear fracture like that. So we'll continue our journey in future classes, particularly in upper limb also. Thank you. If you have any question, you can ask. इसका बहुत आवाज आ रहा है यार, somebody is